Hello everyone, so today will be about congestive heart failure. There's different types of heart failure. So there's the acute ones and the chronic ones. So the congestive heart failure actually falls within the chronic heart failure category. So yes, although not all chronic heart failure cases will have congestive symptoms, but then if it's very uncontrolled, then the congestive symptoms will appear. So congestive refers to accumulation of fluid in the body, right? Which then can exhibit symptoms like edema, especially peripheral or ankle edema, because due to gravity, so the water will be pulled down towards the leg area, right? So heart failure, again from the name, refers to almost going to shut down heart, literally. So as you can see at the diagram over here, the heart is almost trying very hard to cope with the demand of the workload, and it's trying not to break down, literally, right? So obviously the heart cannot break down because it then refers to the death of the person. So there's different guidelines which are quite recent, so you can refer to them. And congestive heart failure also refers to an enlargement of the heart as well, because the heart tries to compensate itself. Later we'll talk about the compensation mechanism. So in detail, so in very short terms, is that the heart, when it's trying to pump stronger and harder, so what it does is that there will be some remodeling process whereby they'll try to increase the number of cardiac muscles, i.e. cardiac myocytes. So but remember, the chest cavity whereby the heart is, it has only a very limited space. So the heart muscles, obviously the first way you try to grow outwards, but then eventually it will grow inwards. So therefore taking up the spaces of the heart chamber, so making the heart pumping efficiency to even drop even further, right? So if you do an x-ray, you can see that the heart size is enlarged in a way. Okay, so overall the class will go through a little bit about the physiology, then you understand a little bit more why and how it occurs, right? And a little bit of the categorization, pathogenesis as usual, some treatment aims and strategies, and also the drugs as well. So you can see there's a lot of repetition of the drugs available over here. So sorry, I forgot the dash over there. So ARB or beta blockers around as well. Some diuretics and digoxin for symptomatic control as well. And for very severe cases when they are admitted, so you need inotropes as well. Right? It's for example, adrenaline and so on. So there's different mechanism and which then reflects that contributes to the symptoms of heart failure. So you can see again there's different components of it. So similarly, the contributors of how the hypertension would happen, right? So you've got your sympathetic tone, you got your RAS system, right? You got your smooth muscle cells, which all contribute to increased peripheral resistance, which then reduce the ejection fraction. So obviously, if there's a reduction in ejection fraction, obviously will be translated into a reduced efficiency of the heart per pump, right? So therefore, there's limited cardiac output, refers to the CO over here. So at the early stage refers to a more exacerbation on effort when there's exercise and so on. And for the very late stage, even the person will also experience a shortness of breath even at resting. So it leads to fatigue, exercise limitation, and so on. So with increased water retention, so they'll be due to increased sodium retention at the kidney, leads to increased water retention, causing edema in the pulmonary and the peripheral. So pulmonary edema again contributes to more shortness of breath symptoms. So different classification, obviously when the greater the class, the greater number, so will be worse in a way. So the symptoms even present during resting time, obviously the mortality rate, and this is just for a year, so you can see it's actually pretty high. So we need to control the symptoms and also control the disease progression, right? So how does it work? So in general, our heart, it will try again to compensate and try to work very hard. So it starts off, why will there be an increase in compensation? How does it being triggered? So there'll be a hemodynamic burden, so there'll be an increase in activity, and or a myocardial insult. So basically there's not enough blood supply to the heart. so itself. So the activity of the heart will be reduced. So first thing, that will cause a short-term reduction in the cardiac output and blood pressure. So this causes a reflex compensation of extrinsic, refers to the neurohormonal system, which is your sympathetic nervous system, or your RAAS, your renal angiotensin and aldosterone system, or it can also trigger the intrinsic cardiac hypertrophy or dilation. So the heart will increase its size again, trying to improve the pumping mechanism. So short term, what happens is that you stimulate a stronger heartbeat, right? So therefore, to maintain the cardiac output and maintain the blood pressure and all. But obviously, long term, it causes harmful effects. So because overall, it causes increased workload of the heart, because when there's, for example, when there's increased fluid retention, it also contributes to increase in the blood volume. So therefore, the heart actually has to pump harder than usual as well, because there's more blood circulating around the body. So overall, it causes a progressive, a long-term bad effects. So all this increase in all the blood in the blood volume, or actually will contribute again to more hemodynamic burden. So you can see it's a vicious cycle, so it can triggers it again and again. So it's all in a circle, as you can see. And bear in mind, besides the acute heart failure, so that one happens very quickly, chronic heart failure will take years to develop, right? It takes years. So it starts with, again, with stage 1. Again, you can see all the risk factors over here. So therefore, again, it's very important to control and minimize all the risk factor development, or to keep that under control. Obesity, diabetic and all. So all this over slowly will actually causes hypertrophy and remodeling process. So again, remodeling is scary in a way, because it's not something that you can correct it with medication intake very easily. You can only stop it. You can't really reverse the effect, because remember, any structural change, there's no drug can actually sort of specifically break down your excess cardiac myocyte. There's no such thing, right? So remodeling process, and also increase in arteriosclerosis, because remember, there's cholesterol, increased cholesterol over here as well. So if eventually if it causes a cardiac infarct, so this is when most of the time that people will not be ignoring the symptoms, right? Because over the early stage, it might be more asymptomatic, so it's easy to forget and didn't realize that the person actually has a heart issue. So the sudden death can be caused by arrhythmia due to MI. So if they have an MI, they enter in the hospital, they manage to get enough treatment, so they eventually progress. So if you can manage to treat them and keep the risk factors under control, so you can stop the remodeling process as early as possible, right? So if it's left untreated, it can progress into heart failure. And obviously, you already know that there's not much you can do. If it's really a heart failure case, you need a heart transplant, and you know the chances of getting heart transplant is really, really low, because there's very, very few, very limited donors, so which then eventually causes death. Okay, so this is this is just to show you, and experimentally I'm putting this paper because it's my friend's paper. So it can cause, does it really causes high cardiac hypertrophy? What happens? So they actually did an experiment. So what happens is that the heart, so basically you just cause artificial narrowing of the heart by just tying it, those surgical, just tie it up. So the heart eventually gets enlarged, right? Because there's a restriction in the output. So eventually you can see the heart itself, there's increase in the heart size. That's why in the cardiac myocytes, but it's looser, it's not as compact. See that there's hypertrophy in the heart, so the heart size increases tremendously, and you can see there's a lot of fibrosis as well. So which is not good, because fiberization, which is indicated by the red part, so meaning there's lesser cardiac muscles, because obviously you need muscles to do the pumping work. If it's fiber, you cannot pump, it's less elastic. So eventually the heart again loses and reduces the ability to pump. Okay. So there are two main pathogenesis process in heart failure. So the first part is the cardiac remodeling. So it's the structural changes. So there's apoptosis, fibrosis, right? And also the second part is the neurohormonal, right? And obviously all this will trigger the compensation mechanism. So bear in mind, all this compensation mechanism is what you want to reduce actually, because it's a mechanism whereby it's trying to help for the short term, but eventually in the end it becomes worse. Right? So again, just to put it into flow charts, as you can see over here. So your neurohormonal again is your sympathetic and your RAS system. So eventually, it will trigger more cardiac myocyte growth, because again, if there's more cardiac muscles, you need a stronger blood supply as well to make sure all the cardiac myocytes receive sufficient oxygen and nutrients, right? And obviously it also increases the cardiac energy expenditure, again with more increase in blood flow and things like that. So therefore again it contributes to remodeling and myocyte cell death. So this is just another diagram, so you can see, just to show you the different components. So these different components again refer to where the blood or the drug action can take upon. So you got your sympathetic nervous system, so this is where your beta blockers can act upon to reduce this arm of it. And also you got your renin RAS system over here, and there's also aldosterone as well, and also basically beta blocker and ACE inhibitors, the two main ones as well. Right, so this is just to list down what the overall neurohormonal changes, and again this is in a table form, right? So why is ACE inhibitors and beta blockers very useful in this case, especially ACE inhibitors? If you remember the hypertension class we mentioned before, so ACE inhibitor, because it reduces the angiotensin II effect, which can also contribute, whereby it also contributes to the remodeling process. So if you can actually inhibit or reduce the amount of ACE and angiotensin II activity, you will reduce or stop the remodeling process, which is very, very important in heart failure progression, right? So there's also overall compensation effects, right? So there's also factors here to show you that, and all these are from the same 2019 guidelines, right? So there are also factors that can cause worsening for a person with stable heart failure, right? So for some of them, so again, look through those factors. So if it's also good to let the patients know, so that maybe we can avoid that, so that they don't have to enter the A&E. So you can see that there's also some medication related factors like NSAIDs and COX-2. So again, if the patient has a heart failure, you can try to try to avoid these drugs, or non-compliance, or alcohol, and also excessive salt or fluid intake is also not good for them. Right, so and also severe emotional and physical stress as well. Okay, so these are the factors that can cause the worsening. So how do you treat them? So if you based on the diagram, as you can see, if the ejection fraction of the left ventricular actually reduces to less than 40%, so this is where the sign and symptoms will be more obvious, because you can see them during resting time as well. So again, we try to initiate ACE. Again, you can see ACE inhibitor or ARB. You can see beta blockers over here as well. If there's improvement, so you continue the medication. So if it's not really improvement, so you might top up with other drugs, ivabradine. There's also Digoxin, and also Diuretics if there's edema symptoms, right? And also other drugs over here as well. So when you look at the treatment goals, so the first thing is obviously we try to reduce the mortality rate and the prognosis of the patient. If not, we try to reduce the symptoms and also prevent the progression, right? So here's another diagram to show you where the drugs could act on to actually influence or the hemodynamic effects of the heart failure disease per se. So you've got digoxin over here, right, that can help to increase cardiac output directly. So digoxin is a very old drug, which we're going to go through later, but now it's mainly used for symptomatic control, right? And you've got your ACE inhibitor again over at this arm, and you got your aldosterone antagonist over here, the spironolactons over here, and you got your diuretics again over here to reduce the water retention. So it's also important to know that the drug classes is generally divided into two sections. The first part is the prevention of disease progression. So this is where almost all patients will get it if required, right? Almost all will get it because it prevents the worsening of the whole disease. But there's also others which is mainly just for symptomatic control, because yes, it's helpful in the disease, but it doesn't stop the disease from being worsened over years. So it doesn't help in the overall mortality rate. So ACE inhibitors, so you can see this is the overall how you can change the hemodynamic effects. So again, it stops by over here, so therefore reduces the compensatory preload, afterload, and remodeling process. So it reduces all this. Right, so hopefully from the diagram we can understand how ACE inhibitor or beta blocker works. So again, beta blocker, we reduce the sympathetic signal, right? So it reduces the compensation increase in the cardiac output by a reduction in the force or the rate or the heart rate, and also reduces the preload. So this is another diagram, again similar thing, so you can choose which one is your favorite to refer to, right? And this is the wording of it. So there's different ones which are recommended for to be used in heart failure specifically. So you can see some familiar names over here, right? And some of the ARBs over here as well. So what happens? So this is for beta blockers, right? So if you have a beta blocker drug to stop over here, and don't forget beta blockers has a little bit reduction. Sorry, my boy coughing. To reduce the renin secretion over here as well, so therefore it's good. A little bit of historical information. Actually, beta blocker to be used in heart failure is still relatively newer, right? So it's not new anymore. So probably within past 10 years or maximum 15 years, because beta blocker, from the name of it and the mechanism of action, really know that it actually reduces the heart rate, right? So and remember, in this case of heart failure, you're actually dealing with a very fragile heart, whereby the heart is really trying to sustain itself and not to shut down. It's something that we try not to tip it over, because obviously we don't want to shut down the signal too much, then in case the heart just stops beating. So it's something very recent that they found that if you manage to reduce the heart rate just minimally, just a little bit, with quite a small dose of beta blocker, you can actually help in the overall progression. So this is something pretty new, right? So to improve the long-term symptoms, right? So some add-on points, and bear in mind it's just for very selected beta blockers, and it requires dose titration. It's not something you can just blast in a high dose. So you can only start it when it's stabilized the dose on ACE inhibitors, and there's no more very strong bad symptoms or congestive symptom. Everything is cleared. Then only you start the doses at a very low one and slowly go up to the clinically proven effective dose. So the main point here is the patient has to be stable. So obviously they won't be in ICU, so they will need IV inotropic drugs. So go find out about the side effects and contraindications as well. So you can see here there's some only a few of them which are recommended. So the more popular options would be the bisoprolol and carvedilol, right? So there's some target dose. So you can see the initial starting dose is really tiny and baby, right? So once they can tolerate and everything's going up, then they only slowly increase all the way up. You can see the target and the initiation dose is about tenfold, which is like woohoo. Okay, so the need of diuretics in this case, remember, it's for symptomatic control, but it's also equally important as well. So we try to just reserve diuretics just when there's symptom patients, because we don't want the resistance to form, because it's quite common to get resistance towards furosemide. So meaning you increase the drug dosage, but you don't see the effect that you want already, right? So again, compromised function, as you can see overall. Okay, so it starts in the center over here, so you can see it causes increase in the fluid, right? So this is when we try to kick it out through diuretics, right? So this is the hemodynamic response. So again, you can refer to the diagram or the text over here, right? So we want to minimize the overall excessive fluid retention in the body, right? Because excessive fluid retention will cause increased dilation of the cardiac chambers, and then to increase the overall workload of the heart. Which diuretics are most widely used? So to reduce, again, this is some wordings, to reduce the venous return, reduce preload, reduce the congestion. So overall, when this is reduced, the person actually has a relief of this dyspnea, so which is the shortness of breath, so the person can probably do a little bit more exercise. So it's mentioned just now, there's a possible development of diuretic resistance, right? So these are all the possible compensation mechanism in the body, literally, to counter the effect of the furosemide. Right, so there are some drugs here. So you can see another bumetanide. So this is mainly IV form, right? So there's a little bit of thiazide diuretics, but thiazide diuretics in terms of increasing the fluid output is not as strong or effective as the loop diuretics. But there's also here, just to put, because everything is in the same diagram, so there's also mineralocorticoid antagonist. So there's mainly aldosterone, which is more widely used because of a better side effect profile. So here is just to tell you a little bit. So for patients who are on furosemide, they actually be educated. So they actually weigh themselves every day in the morning to be more accurate. So it's impossible for a person to increase more than 2 kgs in 3 days, right? Because it's just impossible. Even though how much you actually eat, right? It's impossible to put on so much lipid in the body. So meaning the extra weight that the patient is experiencing is actually just pure fluid. So they can actually increase the dose of furosemide by themselves, right? So, and to restrict their fluid intake, so they can I think they can minimally drink like 2 liters of water in a day, so until the dry weight is maintained. So however, if there's worsening of symptoms, they actually have to go to see a doctor. Right, so there's other antihypertensive that can be used as well in heart failure, but again, they're not the most popular options because the clinical evidence is not that strong. So just to miss out, there's another drug here called aldosterone antagonist. Again, it's used more recently because they realized that aldosterone actually plays a very important role in the progression of heart failure. So you can see it's again affecting the RAS system. So actually there's the reduction of the water retention. There's also reduction in the remodeling process as well. So therefore it's very, very useful. So in the heart failure, if you can stop the effect. So in Spira, in this case, is aldosterone, right? So, and spironolactone. Spironolactone is an older drug, which is not that selective, right? With greater selectivity with the aldosterone. So therefore it can reduces the side effects towards the sexual hormones, right? Because it doesn't inhibit all the others over here, right? So and so there's more side effects over here, and there's longer metabolites. So because remember, these are all potassium sparing, so you just have to double check the serum the plasma potassium level as well. So just as usual, just check it before, check it after a week, or at least check it after a month. So again, patients with heart failure, they normally have to go through quite a lot of blood tests anyway. So you need to know the mechanism of action. It's a specific class on its own and its effects. So it's tricky and less used now because of one main reason, which is it is a narrow therapeutic index drug. So therefore, it's something that you need to monitor more for toxicity and so on and so forth, because there's a lot of drug interactions as well. So going through the mechanism. Okay, so it continues with the mechanism of action of digoxin. So as you can see here, digoxin actually inhibits this part, the sodium-potassium ATPase. So when this is blocked, so you can see there's less sodium going outwards. Okay. So more sodium over here, meaning there's lesser activation of this sodium-calcium pump. So less activation, meaning there's more calcium which stays within the cardiac myocyte. So more calcium here, more calcium which remain in the store, remain to be able to be used within the cardiac myocyte cells, which then causes increase of myofibril contraction. Right, so the net effect that we want to get is actually increase in calcium concentration and increased contractility. So therefore, the heart can pump better. Right, so the current evidence in a way is not as current as it is in this paper, but it's still, I'm just trying to show you that there's a lot of studies which says that if you use digoxin in a way, it's not really that useful for heart failure in terms of its progression. However, in the guidelines it's also mentioned that digoxin is also a useful drug for arrhythmia. So therefore, if the patient is experiencing arrhythmia and heart failure, digoxin is a very if the patient experiences both symptoms, so you can actually use digoxin to have control with both sides. So therefore it's very, very useful in that case. But don't forget, it's also very useful if the patient is experiencing very, very terrible symptoms, as mentioned, I think I mentioned in the class before. So got cousinish, further relative. So and heart failure is something that I remember it happens in most of the time in older population because it's a chronic disease. So in terms of chronic, in a way, some people, they have other concomitant diseases like asthma or COPD, which also affects the respiratory function, overall also contributing to a shortness of breath. The stamina of the person can be so bad that the person cannot finish talking a simple sentence, without catching his own breath. So basically, the person, I remember very very clearly, she's like, I cannot, yes, order this, please. It's very bad. So, and they can even get the orang cacat, the disabled sticker for the car as well, because they can't really walk very far as well. So this is how bad things could be. So for this, for certain patients which has very bad symptomatic control with all the other drugs, so it's also good to top up with digoxins to try out. Okay, so this is the whole text of digoxin's function in arrhythmia. So it's really long. I didn't really cut it because every sentence is a point in the way. So there's inhibition of sympathetic nervous outflow and so on and so forth all the way down. So yeah, basically you can just go through. So what's behind the troublesome use of digoxin is actually due to there's a lot of interaction. First of all, you can see it has a terribly long half-life, one of the champions in the drugs. So it affects the dosing in a way. So basically, obviously, it's very difficult to use every other day dosing and so on and so forth. So we still use an OD dosing every day, but use it at a baby dose. So again, it's very difficult to kick the drug out of the system if there's any toxicity, if happens. So there's actually an antidote developed for digoxin, which is called Digibine. You can just find out more details in BNF. It's also mainly excreted with the renal. So remember, a lot of people with heart failure, they probably have a little bit of renal failure as well, because they might have a little bit of hypertension and so on, which again can contribute to deterioration of renal function. So you might need to adjust the dose of digoxin over time as well. So and again, it's a narrow therapeutic index drugs. So go find out what's the symptoms of toxicity. It's something which can easily be found, be detected, because it changes the vision, right? So you can see things in a different color. So go find out about it. I think it's yellow, right? Everything is in BNF anyway. So there's different toxicity. When can it happen? It can happen in hypokalemia as well. So, and also there's also other drug interactions. Go find out. So there's some text over here. You can read through about it. So go find out from BNF what are the important drug interactions as well. Okay, so that's your homework. Right, so there's also some inotropes that can use for heart failure patients. Again, they're used for in very severe cases whereby you actually need extra stimuli to make sure the heart keeps on pumping. So it's mainly the person most likely will be in ICU or cardiac ICU, or you call it CCU. So again, all these details of all these drugs like dopamine, norepinephrine or adrenaline, noradrenaline. So all these can be found. You already learn it in your earlier years in the pharmacy school. So go find out more details there. So which is in the peripheral nervous system class. So hopefully you can still remember them. So again, it's we've got the question before that someone pointed out. It's actually an opposite action with beta blockers. Yes, that's why beta blockers, you only use them under stable conditions, but inotropes, you use it under critical conditions whereby you literally just trying to maintain the life of the patient by maintaining the heart pumping. It's as bad as that. Then only use it. So again, you can activate your alpha and also your beta 1 receptors. So the main effect that we're looking for is actually the beta 1 and also the alpha 1, again to maintain the heart function. Details you can just read through. So these are sympathomimetics, because all these components are also produced endogenously in the body, right? So basically indication is just to maximize thing when every other thing has failed. So when you look at the hemodynamic effects, again we try to improve the heart rate, improve the stroke volume by improving the contraction strength and things like that, to overall cause maintaining the cardiac output of the patient, right? So these are all the details. So you can something you want, right? So which actually causes vasodilatation. Okay, so overall you can actually predict that the patient will probably experience quite a drop in the blood pressure, because there's reduced in blood pressure by both sides of the drug, right? So it was quite exciting when it's out, but then we realized in actual practice it's actually a little bit tricky, because they actually have to slowly titrate the drug. Again, it's about timing and titration, but it could be a little bit more tricky to titrate because it's a combination of drugs. So probably you might need to start off with valsartan first, and if it's stabilized and all, then you might need to withdraw that and top up with this drug. Right, you change it into Entresto, right? Because remember, again, in heart failure patients, the heart condition is very fragile already. If you cannot reduce the pressure to be too low, because if not, the heart could not function, right? So however, in general, it's also called ARNI for the class drug. So it can be used as a replacement when they still remain symptomatic, right? So they can still be to swap it over to Entresto for specific patients which do not respond well with the standard drugs. Okay, so ivabradine, so you can see it in the heart failure as in the guidelines as well. So it's basically a bradycardic drug. So you see this in the angina class as well. So it's a repeat. So basically, again, just to repeat, so it's actually an alternative for beta blockers, right? Because there are some people who cannot tolerate beta blockers, like people with asthma and so on. So ivabradine actually selectively blocks the sodium channels in the heart, so to reduce the depolarization to cause a pure heart rate reduction. So at the SA node. So there's different drugs as mentioned over here in terms of the grading. So you can see again as repetition. So remember diuretics, don't forget, again, you can find out in the diuretic class. So it's not shown to improve survival, but yet it's still very important for symptomatic control. So for all patients, they'll be on ACE inhibitor or ARB with beta blockers. So this is for all of them. So there's some top up for the others. So it's very common for them to get 3 drugs at least. So again, a lot of counseling involved. All right. So if they're still not very good, then they might need other non-pharmacological therapies, right? So for cardiac resynchronization therapy. Okay. So again, all this will be under the cardiologist. Okay.